Good morning. My name is Rajendra Irani and I'm a senior emergency care nurse in HSC Ireland. Today I'm going to present regarding sepsis recognition and management. But please remember, this is a very short video designed for the information of registered nurses who are practicing in India. So the main objectives of this short video presentation is enable the nurses to assess an acutely deteriorating patient and apply the assessment and diagnostic criteria for sepsis in a timely manner. Manage sepsis with a sepsis 6 bundle. That is, I'm going to explain regarding what is sepsis 6, that is, take 3 and give 3, and apply its principles for better patient prognosis and communicate effectively within the healthcare team. So before you proceed, it's very essential to understand the meaning of the following terminologies such as infection, SARS, sepsis, severe sepsis, and septic shock. So infection, it's a pathological process caused by invasion of normally sterile tissue or the body cavity by pathogenic organisms. SIRS, that is SIRS, which stands for Systemic Inflammatory Response Syndrome. It is an exaggerated defense response of the body to noxious stresses such as infection, trauma, surgery, acute inflammation, ischemia, reperfusion, or malignancy. The main purpose of this SIRS is to eliminate the source of insult to the body. Sepsis. Sepsis is a combination of suspected source of infection and the systemic inflammatory response syndrome. Sepsis, severe sepsis is sepsis with one or more end organ failure. And the septic shock is the hemodynamic instability despite intravascular volume repletion. That is after the fluid resuscitation at 30 ml per kg, if the patient is not showing the response or if still the hemodynamic instability continues, that's the indication for the septic shock, in which case patient need the pressors to maintain the hemodynamic stability. In this stage, circulatory shock with the signs of severe organ dysfunction or hypoperfusion is evident. The common source of sepsis in terms of the body system, that is respiratory 35%, urinary 21%, intra-abdominal 16.5%, and next one is this soft tissue or intra-articular 11.3%. So this data has been obtained across US, Europe, and Asia in 2014. So what will happen if you're not treated infection effectively at the initial stage? So let me use my highlighter here. There's a point, yes. So we have to treat the infection effectively. And if it's not treated effectively, it will progress to SIRS, that is systemic inflammatory response syndrome. And if it's easy to stop this whole process at this stage, if not, it will progress to sepsis. Then the severe sepsis. Once the patient is entering to this stage, getting back to this stage is somewhat difficult. But if the patient went into septic shock, the chances of prognosis is very low and the mortality rate is extremely high in this case. So as a competent nurse, always we have to be mindful to observe the signs and symptoms for the SIRS markers. That is, includes temperature of more than 104.4 degrees Celsius, Fahrenheit, or less than 96.8 Fahrenheit, heart rate more than 90, respiratory rate more than 20, WBC count less than 4,000 or more than 12,000, and also the capillary blood glucose level more than 7.7 mmol. I think in India, we are using the parameter milligrams per DL, that is approximately 135 to 130, more than 135 to 138 milligrams per DL. And if the patient has 2 or more above, that is high temperature, tachycardia, tachypnea, increased WBC count or very low WBC count, and the blood sugar level elevated. If any of these two criteria seen in the patient, then patient is positive for this SIRS. But please remember, sepsis recognition includes the NEWS, that is new early warning score system, sepsis pathway, and the clear escalation protocol for the higher care. They're all the integral part of sepsis management. But in today's presentation, I'm going to explain only regarding the sepsis pathway. If anyone interested to learn more about news in sepsis pathway in detail on the escalation protocol, please let me know, and I can organize one separate webinar on the news, sepsis pathway, and the escalation protocol. So this is the sample form of sepsis screening form in HSE Ireland. But for easy understanding, I'm going to break down each sections for easy understanding. So it includes section 1 to section 8. So section 1. So as a nurse, you can suspect the infection in a patient. One second, let me use the pen here. Okay, it's not taking me there. Okay, that's fine. So you can suspect the infection, or patient will present to the department with SIRS marker, what I explained in the last slide. Then we have to suspect the source of infection or suspected infection. It can be respiratory, intra-abdominal, that whole system you have to observe. Where is the source of infection or possible source of infection? Example, if the patient is coming with fever, shortness of breath, hypoxia, productive cough, then you can suspect the source of infection coming from the respiratory tract. Or if the patient is having the chills, lower abdomen, dysuria, hematuria, then we can suspect the source of infection coming from the urinary tract. Or if the patient is having the long-term urinary catheter, and if the urinary catheter is draining a foul, smelly, cloudy urine associated with fever and chills, yes, source of infection possibly from the catheter. Or if the patient is coming with altered GCS, confusion, neck pain, photophobia, fever, they're all signs of the central nervous system infection. So we have to be very mindful to just to suspect the source of infection when you are collecting the history from the patient or when you are observing the patient in your daily care. Sometimes it's hard to identify the source of infection at the initial stage, so then it can be unknown. But if the patient, if there is no source, suspected source of infection, then no, if there's no clinical signs of infection, then no need to proceed with this sepsis pathway. In section 3, we are going to decide who needs the sepsis 6 bundle. That is, sepsis 6 includes infection plus one of these following. That is 1, 2, 3. 1 second, where I can use my pen here. Okay. So if the patient is having the infection, a suspected source of infection, and it meets one of these 3 criteria, then we have to commence this sepsis 6 bundle. That is, patient at risk of neutropenia due to bone marrow failure, autoimmune disorder, or treatment including but not limited to chemotherapy or radiotherapy who present unwell, or if the patient shows the signs of the new organ failure, that is acute altered mental status, oliguria or anuria, non-blanching rash, respiration more than 30, decreased capillary fill, low saturation, that is less than 90% on room air, heart rate more than 130, systolic blood pressure less than 100. And in third category, if any patient, patients with SIRS marker, what I explained earlier, these are the SIRS markers, that is tachypnea, tachycardia, in a low or high WBC count, increase or that is pyrexia, or if even the low temperature also comes under the SIRS, and the hyperglycemia. These are all the signs of the SIRS. So if the patient meets the criteria, SIRS plus one of the comorbidity, which includes COPD, diabetes, HIV or AIDS, chronic liver disease, cancer, chronic kidney disease, immunosuppressant medications, age more than 75 years, frailty, or even recent surgery or major trauma, all part of the comorbidity. So if the patient meets the criteria for the SIRS and the comorbidity, that is one of the indications for the commencing the sepsis 6 bundle. So before you proceed to the next section 4, you have to, that is section 2, we identify the suspected source of infection. And in section 3, we identified who needs the sepsis 6 bundle. And in section 4, when you go, yes, there is this, what is it? We established sepsis will commence this sepsis pathway. If no, terminate this pathway at this stage and treat the patient as if he's having the infection with the appropriate antimicrobials. So in next section includes treatment, risk stratification, and escalation. So treatment includes sepsis 6 bundle. This is the most important. So take 3 and give 3. So what we are going to take? So we are going to take the blood culture before administration of any antimicrobials. Next, the routine blood test, which includes the full blood count, urea and creatinine, liver function test, coagulation profile, and one of the most important is the lactate level. So lactate level can be measured immediately. That is, with the ABG syringe, take the venous or arterial blood sample and run it in the ABG analyzer, and you will get the results within 30 seconds. And the monitoring hourly urine output. So these are the part of take 3, that is blood cultures, blood test, and urine output, hourly urine output. Next is the give 3. So what we are going to give? So first is oxygen. So you have to give the oxygen and you have to titrate it to maintain the saturation of 94 to 98%. And in case of COPD patient, maintain the saturation of 88 to 92%. And next one is administer the fluids. It's recommended to administer the fluids at 500 ml, give the 500 ml of normal saline start dose. And if there is a severe hypotension, then you have to give the fluids at 30 ml per kg. Next one is administer the antimicrobials. So these are the components of sepsis 6 bundle, that is take 3, blood cultures, blood test, and urine output. And the give 3 components includes oxygen, fluids, and antimicrobial. So togetherly, take 3 and give 3 comprises of the sepsis 6 bundle. So next one is risk stratification. So always you have to look for the new organ dysfunction, which includes lactate more than 4 after administering the fluid 30 ml per kg. And the cardiovascular signs include systolic blood pressure less than 90 and the MAP, that is mean arterial blood pressure, less than 65. In the next slide, I'm going to explain what is the formula for the MAP and how to calculate it. And respiratory failure, respiratory dysfunction signs includes more need for the oxygen. So initially, the patient may be receiving 4 liters and the patient maintaining the saturation of 94 to 98. But as the organ dysfunction progress, the patient needs more and more oxygen to maintain the saturation. So other signs includes creatinine more than 170, bilirubin more than 32, and platelet count less than 100. And the central nervous system signs includes acute alteration in the mental status. So these are the signs you have to monitor, signs and the laboratory data you have to monitor to identify the new organ dysfunction. And next in section 8, always you have to look for the signs for the septic shock, which is patient needs inotropes or depressor to maintain the mean arterial blood pressure more than 65. That is the sign of septic shock. So in this case, take the patient to the higher dependency care, implement all the required measures as guided by the consultant or your local policy to treat the patient with septic shock. And always be mindful, reassess the patient irrespective of what stage patient is in, either in septic shock or severe sepsis or infection. Always reassess the patient's clinical response frequently. Even if you give these 3, that is give oxygen, IV fluids, antimicrobial, look for the patient's response. Is the patient is responding clinically well or not? And repeat in lactate. And if the first one is abnormal, repeat in 3 hours, but it's more ideally recommended repeat in 1 hour and see the clinical prognosis. If the lactate is increasing, it's not a good sign. If the lactate level is coming down, yes, you're heading in the right direction. And if the patient is deteriorating despite appropriate treatment, always seek expert help for the better patient care. Once all the, in the next, as I mentioned earlier, I'm going to explain regarding the formula for the how to calculate the MAP, that is mean arterial blood pressure. So that is diastolic blood pressure times 2 plus systolic blood pressure divided by 3. That is, if for example, if the patient blood pressure is 100 by 60, so formula is diastolic BP times 2 systolic BP divided by 3. So diastolic blood pressure in this patient is 60 times 2 plus systolic blood pressure 100 divided by 3. That is 120 divided plus 100 divided by 3. So equals 220 divided by 3. So patient MAP is 73.33. So approximately 73. And remember, normal MAP is 70 to 100. So once all the nursing interventions has been carried out, document in the nursing notes clearly and communicate to the uh, multidisciplinary team or even to the next handover staff. Thank you for listening. Be safe and stay safe. So as I mentioned earlier, if you need any further assistance to learn about news, that is new early warning score system or escalation protocols or even the sepsis pathway in detail, please let me know and we can organize the separate webinar on these topics. Thank you very much.